Hello, everybody. This is Jonelle, Josie, and Layton, and we are giving you our presentation on lung cancer. And our patient had a robotic-assisted thoracoscopic procedure done with lobe removal. Yeah. So this is our patient. He is Robert, but goes by Bob Jackson. He's a 67-year-old Caucasian male. He's a retired Navy veteran, and he was in the Navy for 20 years. He has a history of COPD, hypertension, pulmonary hypertension, and a 2-pack per day, 30-year smoking history, but he did quit 10 years ago. While in the Navy, he was exposed to asbestos from his ship that he was on. He lives in a home with his wife, Ava, whom he has been married to for 40 years. They have 2 kids. His wife, Anna, is 30 years old and lives in Ohio with her husband and 3 kids. His son, Royce, is 28 and lives nearby with his wife and twin girls. Bob identifies as Christian, and him and his wife attend church every Sunday. He has been hospitalized twice in the past 2 years for COPD flare-ups, and he had a total knee replacement 3 years ago. The history of this medical diagnosis, the patient was at home with his wife and he was mowing the lawn. He started getting short of breath. He took his albuterol, but it didn't help with the shortness of breath. So he thought he was having another flare of his COPD. And he also developed chest pain, which was something new for him. So his wife drove him to the ER. While in the ER, the patient stated, my out of breathness has been more frequent in the last couple months, and he states that his cough just won't go away. He admitted he has not used all his inhalers every day because he forgets. And he stated, it's probably because I'm a senile old man now. His O2 sats for 85% on room air, so he was given supplemental oxygen by nasal cannula at 4 liters. Coarse crackles were heard bilaterally at the lung bases. His blood pressure is 184/92, heart rate 109, respiratory rate 34. ABGs were drawn, and it showed a pH of 7.25, which is acidotic, and pretty much a normal bicarb of 23, and then his PaCO2 is 54, which is high. His troponin is 11, which is also high, but his ECG just showed sinus tachycardia, and it didn't show any signs of ischemia. CT scan showed a 2-centimeter tumor of his lower left lobe of the lung. A PET confirmed malignancy and with no evidence of metastasis. Tissue biopsy confirmed non-small cell lung cancer, localized to the left lung without the plentiful vascularization, which we wouldn't be able to do a RATs for if there was a lot of vascularization around the tumor. Bob is scheduled for a RATs, and that's the procedure that they're doing to do the lobectomy in the morning. The patient stated, I hope this treatment works. I can't think about leaving my family behind, as the patient states through tears and is visibly shaking while avoiding eye contact. So lung cancer is mostly caused by the inhalation of carcinogens, which we all know is mostly smoking. Other carcinogens include radon gas exposure, and then occupational environmental agents such as asbestos, which our patient has also been exposed to. Arsenic, nickel, and radiation. Genetic mutations can also lead to lung cancer. Lung cancer occurs with an epithelial cell in the lung and has a carcinogen bind to it and thus damages the cell's DNA. This change in DNA causes cellular changes to occur in abnormal cellular growth, eventually leading to a malignant cell. As the DNA keeps replicating and passes itself into its daughter cells, the cancer becomes unstable, eventually transforming the normal epithelium into an invasive carcinoma. Symptoms of lung cancer are often gradual or asymptomatic. The symptoms that present depend on the size and location of the tumor, as well as how much obstruction and metastasis has occurred. The most common presentations of lung cancer are the shortness of breath, the dyspnea, change in chronic cough, but I can't say this word. Hemoptysis, chest and shoulder pain, and pain throughout the body. So the surgical procedure that we call RATS, it's a robotic assisted thoracotomy. It's a procedure in which they create a surgical opening into the patient's thoracic cavity utilizing a robotic system. The robotic system allows the patient to not have their whole thoracic cavity opened and instead go through small incision, which can help with healing and recovering. A lobectomy is performed most often when the tumor is located near the outside of the lung, as well as having minimal blood vessel involvement. This procedure was selected for our patient due to the stage of the tumor, its location, and the type of the tumor. After surgery, the patient has a chest tube system initiated because the lung collapses when the pleural space is accessed. One chest tube is placed to help drain fluid, and another tube is placed to remove air accumulated from surgery and to help with reinflation of the lung. Chest tubes are often removed earlier in robotic-assisted thoracic surgeries. Our secondary diagnosis is COPD. This is a progressive lower respiratory disease, which means it moves kind of slowly in time, and it involves both emphysema and chronic bronchitis. So it worsens with age, obviously, because you have a decrease in lung function as you age. The lungs try to repair themselves from the chronic obstruction, but this just leads to a persistent inflammatory response, which we all know inflammation causes scarring. So the scarring of the lung tissue, damage to the alveoli and bronchioles, eventually leads to hyperinflation of the lungs and pulmonary hypertension. The patient can also have an excess of mucus that thickens the bronchial tubes, making it difficult to get air out of the lungs, and they could develop emphysema. The alveoli normally transfer oxygen to the blood and push CO2 out, but when they are damaged, a person may not be able to get a full breath, and this results in impaired gas exchange. The major risk factors are smoking, occupational hazard exposure, and increasing age. Our patient has all of these risk factors. This can, the cilia, which protect the respiratory tract from carcinogens, gets damaged from smoking, and this allows them to accumulate in the epithelium, the carcinogens from smoking, and bind, thus damaging the cells and increasing the risk for mutations causing cancer. Smokers with COPD are 6 times more likely to develop lung cancer. As the lungs age, it has a decreased ability to repair itself, and COPD and smoking drive the aging process of the lungs. COPD also limits airflow, especially in the presence of emphysema, which increases the amount of carbon dioxide in the lungs and increases the risk for lung cancer. So our orders are, sorry about that. Our orders are, the first one is just to maintain our O2 between 89 and 92%, which we all know to keep it lower with a patient with COPD, just because their drive for air is different than a normal person. So the rationale, which I just kind of already told you, but this allows the lung to basically just have oxygen and like keep a continuous flow of oxygen. And then we'll also be using an incentive spirometer to help to prevent atelectasis and pneumonia. And this works by providing visual feedback when a patient takes deep breaths in order to maximize inflation of the lungs. You're maintaining head of bed 30 to 45 degrees. So the rationale for this is you're sitting upright, and this allows fluids to drain normally. And it also permits the residual air, so that extra air that's in the lung, to rise into the upper pleural space and remove via the chest tube. So that's after surgery. Maintain and monitor chest tube site with vital signs, and monitor drainage in chest tube chamber and at incision site. So the insertion site should be checked at least every 8 hours for signs of infection. So you're looking for that redness, any swelling, any like pus stuff, and air leaks. So like the subcutaneous emphysema. So you're gonna palpate and feel any like Rice Krispies or crippling, I don't know if I'm saying the right word, or dislodgement. So it's really important to look for dislodgement, because if that chest tube comes out, then obviously they're not getting that negative pressure that they need to make a full inhalation. Measure intake and output every shift. And then if they aren't getting the proper amount of output, doing a bladder scan and then possibly a straight catheterization. So the patient may have low urinary output with activation of the RAS system. So this could be due from stress from the surgery or even just from anesthesia. And this can cause a fluid to build up systematically. And then just monitoring the renal function in general is important to avoid renal failure. And then lastly, we want a continuous cardiac monitoring. He is under a high amount of stress, especially with the low oxygen. He's losing a part of his lobe of his lung. So arrhythmias can develop due to the hypoxia and the procedure itself. So careful monitoring allows for early detection and treatment with antiarrhythmics.
So now we're going to talk a little bit about the medications that we would use with our patient. So the first med order is 5 to 25 micrograms, 1 puff daily of umeclidinium and vilanterol. So this medication is fast acting. It is an anticholinergic inhaler, and this helps with bronchodilation as well as vasodilation. It also counteracts bronchospasms, which can help the patient ventilate better, especially in cases of COP like our patient has. Some particular nursing considerations that we would really want to see a nurse implement when administering this medication is assessing your lung sounds, assessing the patient's pulse and blood pressure before you initiate this therapy, and periodically throughout therapy. You're also observing for paradoxical bronchospasms and hypersensitivity reactions. And you also want to be aware that this medication may cause hypokalemia as well as hyperglycemia. So there are protocols in place to help with both of those. What you would want to tell your patient about using umeclidinium and vilanterol, you always want to hold the device so it's level and horizontal, and you never want to exhale into your device. You don't want to use this medication in acute symptoms. So if it's an emergency, obviously use like the rescue inhalers and all of that if that's indicated, or seek emergency treatment. The patient also needs to self-monitor for urinary retention, palpitations, chest pain, rapid heart rate, tremors, or nervousness. And if any of those were to occur, they should call their provider or seek emergency care if it's severe. The next medication order is 90 micrograms, 2 puffs every 6 hours of albuterol. So albuterol is a fast-acting and anticholinergic inhaler. Much like the previous medication, it causes bronchodilation and counteracts bronchospasms, and they help patients ventilate better. Again, nursing considerations, you are assessing your patient's respiratory status before you give this medication. You are assessing the rate of their breathing, the breath sounds, how hard they're breathing, the degree of dyspnea that they have, also their pulse. Again, you're not using this for acute symptoms. If your patient all of a sudden is having issues breathing, you're going to initiate other measures to ensure that they can get proper oxygenation. And you're also monitoring again for signs and symptoms of a hypersensitivity reactions, and calling your provider as the nurse if your patient develops a severe allergic reaction to the medication. For patient education, you are teaching your patient to contact the provider if their shortness of breath is not relieved by the medications or is presenting alongside of other symptoms such as like diaphoresis. You let them know that that's excessive sweating, dizziness, palpitations, or chest pain. Your patient should also understand by the end of your teaching that if there's no response to the usual dose that they're on, they should contact their provider to come up with a further plan of care and potentially change up that medication regimen. The next order is 100 micrograms, 1 puff daily of fluticasone. Fluticasone is a corticosteroid and long-term beta-2 agonists. They're combined. This can help improve symptoms of COPD as well as improving lung function. And the reason they're combo is because corticosteroids do not help improve lung function in that capacity. So you need something else to help with that. So for your nursing assessments, you are addressing adrenal insufficiency. You are watching for anorexia, nausea, weakness, fatigue, hypotension, hypoglycemia, all things that would indicate that the adrenal system is not compensating well with the corticosteroid. And you're also monitoring for that hypersensitivity reaction just to make sure your patient is, not having an allergic reaction, because that would not be good. For patient education, you're going to teach your patient to stop the medication immediately if signs and symptoms of a severe allergic reaction occur. For inhalation, use the spacer that is provided and slowly, and I should say deeply, breathe in and hold the breath for as long as possible. This is just so then you can help the medication get better absorbed into the lungs. Morphine is another medication. The reason that it's not complete-ish in terms of dosing is because the dosing is largely based on the patient's needs and kind of what the provider wants in terms of pain management. So again, this is used for pain management following a lung procedure and chest tube placement, which can be quite painful. This would likely be hooked up to a PCA pump in the hospital for patients to control their pain medication regimen. And there's other forms of morphine too that the nurse can administer, but PCA is the most common. As the nurse, you're going to be monitoring of signs and symptoms for oversedation and respiratory depression. These can occur with patients that are on morphine. You'd also want to administer concurrently with it stool softening agents, so like Dulcolax, things like that, laxatives to help, because opiates can cause constipation. And in the case of like respiratory depression or oversedation, you would want to administer naloxone, which typically is ordered as well whenever morphine is ordered. Your patient education is going to be primarily focused on teaching the patient about how do they use a PCA pump. Most people don't really know what they are. And so really letting them know, okay, when you use it, don't let other people use your PCA pump. Like, don't let them push it if they use all that. You also want to educate your patient on using your call light, if need be, due to the dizziness and drowsiness, if you need to get up and go to the bathroom, just because we want to prevent falls from happening, and morphine can definitely cause those reactions. Lisinopril is another medication. It's kind of based off of what the patient needs again. It's given to treat both high blood pressure as well as pulmonary hypertension. As the nurse, you are monitoring for signs and symptoms of angioedema. You're also watching for orthostatic hypotension, as this can lead to an increase of falls. You want to make sure that as the nurse, you're remembering, give your patient their call light. You are making sure the bed is locked and lowered into the lowest position, making sure side rails are up as appropriate, so then they don't accidentally fall over while you're not there, or even if you're there, that you take the measures of using all the correct safety equipment to make sure they don't fall. Your patient education is largely going to be focused on teaching them about angioedema and kind of like the swelling that can occur in their mouth, as well as orthostatic hypotension, and just, getting up slowly. It's okay to, sit up, sit for a minute or two, then sit on the side of your bed. Just really emphasizing with your patient slow movement to avoid the orthostatic hypotension. In terms of diagnostic testing, we went about diagnostic testing in the sense of what are we doing to kind of get our patient prepped and diagnosed before a RATS procedure with lung cancer. How do we even know our patient has lung cancer? So there was the PET scan that was performed. Our patient result was that the tumor shows brightly on the scan. It lights up like kind of a Christmas tree where that cancer is. A normal person's PET scan, nothing would light up. It would all just kind of look normal. So this test is used to diagnose a malignant tumor, which is also consistent with lung cancer and kind of showing where that cancer is located throughout the body. So our expected treatment for returning the patient to baseline. So this treatment really allows the medical team to evaluate the spread of the cancer. How far has it gone? How many lymph nodes are involved? All of that good stuff that has to do with how far the cancer spread and staging that. They can also make more of a plan for tumor resection and kind of, again, with that spread, seeing if it's more localized or if it's not. If the test was repeated after a removal of the primary tumor, it would show no evidence of the tumor, or it could indicate the need for adjuvant chemotherapy just to ensure that the cancer is completely eradicated after resection. A tissue biopsy is also very important in terms of diagnosing lung cancer. So the biopsy can confirm the non-small cell lung cancer in a normal patient. The biopsy would come back as not having cancer. There wouldn't be any cancerous cells in that biopsy. So this is a differential diagnostic as it can differentiate between small cell and non-cell lung cancer, as well as even just saying, oh yeah, this is a cancerous mass that is growing. It allows the medical team to decide how to proceed with the treatment of the cancer. If it were a small cell cancer, the rats would not be done just because small cell cancers, they're rapidly dividing, and a rapidly dividing cancer is not something that the rats can do just because it would have already spread so far. The CT scan, or computed tomography, it confirmed the presence of a 2 centimeter tumor. In a normal patient, this would have no tumor. You wouldn't see anything besides the normal structures that are supposed to be there. So this test specifically helped to confirm the presence of a tumor, but it can't really diagnose the tumor as cancerous or non-cancerous. You can only kind of start to see where that tumor is. Another thing not mentioned on the slide is that it can really help differentiate between if it's something else versus lung cancer. You know, are you having a pulmonary embolism? Are you having, you know, all those things that it could potentially be? It rules those out. So this test showed the medical team the presence of the tumor, which led to the eventual diagnosis of lung cancer. The treatment would depend on the type of tumor and its location. So this is, the CT scan is kind of a good starting point as to, we have kind of this initial image of the tumor and how do we go about treating it. And so other tests are kind of ordered after that. The next test that's really important for diagnosing cancer are arterial blood gases. So our patient's result, pH of 7.25, bicarb of 23, and a PaCO2 of 54. The normals are listed below. I'm not going to go through all those. In COPD, patients have a difficult time getting rid of the CO2 in their lungs. So it moves through the blood and results in hypercapnia and respiratory acidosis. So you're seeing more of that excess CO2 in your arterial blood gases. This is the patient's baseline kind of due to their COPD. So what's normal for them might be abnormal for someone who doesn't have COPD. And so the patient is kind of not expected to return to within the defined parameters, what's in the parentheses, just because they have COPD and that's not going away. You would continue to titrate your oxygen as appropriate and evaluate if further signs and symptoms of respiratory distress were to occur. I know at our clinical site, the only way to get an ABG done was for an emergency situation. They don't just do them kind of willy-nilly. There has to be a real good reason on why you're doing an ABG. The last diagnostic test that we kind of focused on for lung cancer is your complete blood counts. So our patient had white blood count 7.2, RBCs of 6.2, hemoglobin of 14, hematocrit of 49, and platelets of 200,000. And so how these results kind of relate in terms of elevations and whatnot. In order to help move some of the carbon dioxide out of COPD, patients with this disease end up creating more red blood cells, resulting in an amount greater than normal. So that's why the red blood cell count in our patient was 6.2, and you know that's elevated compared to the normal in the parentheses. Again, like the ABGs, this was kind of the patient's baseline due to their COPD, and they are likely just to not return within defined parameters. However, the CBC can also be important for diagnosing things like infection. So again, since we focused on this before the procedure, that wouldn't be affected yet, but you'd be monitoring the CBC afterwards for signs of infection. And even too, like if they did start chemo, you'd be watching those CBCs like a hawk. So our primary nursing diagnoses that we came up with for our patient, Mr. Jackson, the first one is impaired gas exchange related to decreased lung expansion and lung tissue, as evidenced by those ABG results, oxygen saturation of 85%. He rated his pain 6 out of 10 at rest seconds and shortness of breath at rest. Our second primary nursing diagnosis is ineffective airway clearance related to the fluid buildup in the lungs after surgery, and then characterized by non-productive cough, crackles in the lungs bilaterally. Patient statement: I have so much crap in my lungs, I just can't cough it up. And again, this is also kind of related to the fluid buildup in the lungs after surgery due to the excess amount of mucus being secreted in the lungs.
Okay, so sorry about that. I was not unmuted. Our primary nursing diagnosis was the impaired gas exchange related to decreased lung expansion and volume and tissue, lung tissue. And it was evidenced by the crackles, the ABG results, the high respiratory rate, the oxygen saturation being low, the pain 6 out of 10 at rest, and then the shortness of breath at rest. And for our overarching goal, we want the patient to have improved oxygenation by discharge. This patient, so for our OCCs, our first one is the patient will have normal breath sounds in both lungs, or normal for him, within 1 month of recovery. Our second OCC is the patient will have fine crackles within 2 weeks of recovery. The third one is that this patient will have a resting respiratory rate between 12 and 18. The fourth OCC is this patient will ambulate 3 times daily with oxygen for the next 24 hours. The fifth OCC is this patient will do deep breathing and coughing exercises 2 times every hour until discharge. That includes like incentive spirometry. The sixth is that the patient will drink 2,000 milliliters of fluid every day to help loosen the secretions and ease the cough. The seventh is this patient will be on room air when not ambulating. The eighth is the patient will demonstrate effective use of prescribed inhalers by discharge. The ninth is the patient will demonstrate a breathing pattern that supports alleviation of respiratory acidosis by discharge. And the 10th is the patient will express a decrease in pain by discharge. So our first nursing intervention is that the nurse will perform a respiratory assessment to determine pulmonary function. And the reason we want to do this is to collect baseline data and monitor if the condition worsens or improves. This patient just had a removal of his left lower lobe, and it would be normal to have some limitations of lung function. However, he also has comorbidities to include COPD. The patient has been receiving opioids, which can also induce respiratory depression and sedation. Our second nursing intervention is the nurse will encourage the use of an incentive spirometer 10 times every hour to monitor pulmonary function and breathing exercises. We know that the use of an incentive spirometer determines if there's any degree of airway obstruction by measuring the force of exhale within 1 second, which is the FEV1. It can also be used to determine the use of bronchodilators, if it's effective or not, by measuring the FEV1 after administration of it as compared to before the administration of the bronchodilator. Slow, relaxed breathing, which can also help control anxiety during periods of stress. This is important for this patient because he already expressed anxiety for us. And it's also just a good pulmonary exercise. Pursed lip breathing, and that will also help control breathing and slow the respiratory rate down, and that'll help improve oxygen transport. And then our third nursing intervention is the nurse will continue to maintain oxygen saturation greater than 90% by monitoring the pulse oximeter and applying supplemental oxygen as needed. So the body adapts to breathing with increased levels of CO2 and less oxygen. Chronic CO2 has COPD, I think that's meant to say, has a decreased breathing response, and the body is stimulated by low oxygen levels instead of being stimulated by increased carbon dioxide levels. This is why it's important for a patient to have lower oxygen saturations, and why it can be dangerous to give them too much oxygen. The patient will need to be monitored closely while on oxygen, especially because he has a loss of lung function. So our fourth nursing intervention was the pulmonary rehab. The nurse will collaborate with pulmonary rehab. It is a multidisciplinary service, which includes teaching the patient breathing exercises, nutrition skills, training, smoking cessation if needed, and psychological interventions This can help our patient to improve and just it focuses on their whole well-being as well as their physical well-being. The fifth nursing intervention is that the nurse will collaborate with physical therapy to strengthen the muscles and the condition of the body by the end of the shift. Physical therapy can help assist the patient in an exercise program to increase muscle conditioning, which can help with feelings of dyspnea and fatigue. The patient can also be taught exercising techniques which can improve energy and ventilation. This patient also can learn the best practices and to improve lung function without physical exertion. Physical activity will strengthen and condition the lung muscles. Muscles are deconditioned, require more oxygen. And the sixth nursing intervention is that the nurse will collaborate with respiratory therapy by discharge. Collaborating with respiratory therapy will help to assess the patient to use his inhalers, when to use them, and other techniques such as airway clearance maneuvers. In COPD, the patient can have an excess of mucus that thickens in the bronchial tubes, making it difficult to get the air out of the lungs. And they also have emphysema, which causes structural damage to the alveoli. This is reflected in our second nursing diagnosis of infective airway clearance. The alveoli normally transfer oxygen to the blood and push CO2 out, but when they're damaged, a person may not be able to get a full breath, resulting in that impaired gas exchange that we see in our patient. Our psychosocial and educational nursing diagnosis. Our first one is anxiety. It's related to the uncertainty of his prognosis, the unknown outcome in the surgery, and the anticipated pain and discomfort after the surgery. This is characterized by the patient's statement of, "I hope this treatment works. I can't even think about leaving my family behind," and then followed by tears, shaking, and avoiding contact or eye contact. This is all indicative of anxiety. Our second psychosocial nursing diagnosis is deficient knowledge, and it's related to the inadequate teaching and misunderstanding regarding the importance of medications. This is characterized by the patient saying that he forgets to take his medication and that he intermittently is not taking it as per the protocol. So for our complications, we have risk for infection, which this is important for this patient because when they do a surgical procedure, any infection is possible. And especially with the chest tube insertion, it's impossibly inserting outside bacteria into the patient. And we really just want to be watching them for those signs and symptoms of infection, like fever, the redness at the site, oozing, the sore throat, chills, induration around the site. For nursing interventions that we can do to reduce the risk, we want to educate the patient and the family on prevention of infection, and we'll also encourage the visitors who are sick to not come and visit the patient. We do not want them introducing any bacteria that isn't there into the patient, because that can lead to infection. We're also going to make sure that we are frequently monitoring vital signs per hospital policy, and just making sure we're really, really closely looking at those sites where the chest tube is inserted. The next complication is pneumothorax. That's because the patient has a chest tube, and if there is a potential for air leaks to occur, especially if there's a faulty chest tube system. Shortness of breath. This would be signs and symptoms of pneumo would be shortness of breath, tachycardia, the increased respiratory rate, increasing distress, and sudden pain and crepitus. A nursing intervention for this would be that you'd want to avoid clamping the chest tube because it can cause a pneumothorax. Instead, in the event the chest tube becomes disconnected, to get into a bottle of sterile saline. You want to secure the tubing connections and avoid stripping the tube because that can also cause a tension pneumo. And our third potential complication is cardiac arrhythmia. This can lead to a chest tube placement can lead to the development of a cardiac arrhythmia. Signs and symptoms of this wouldn't be as obvious. You would most likely see ECG changes is your first sign. Depending on the type of arrhythmia, poor peripheral perfusion and syncope could be possible. You're going to want to closely monitor the ECG or the tele just to see if they have issues going on with the ECG and possible arrhythmia happening. You'd want to implement possible electrolyte replacement protocol depending on the arrhythmia. You could also start antiarrhythmic medications depending on that as well.
So in terms of like discharge criteria, we really want to see our patients, we don't want them to stay in the hospital super long, but we also don't want them, to be uncomfortable. We don't want we love our patients. We want to see them go home though, just because rest at home is better than rest at a hospital. So in order for us to even think about discharging our patient, there are a few criteria that we kind of came up with that we saw a lot on our unit about what we want to see before we say as nurses, yep, we're comfortable with sending our patient home. So the patient will demonstrate improved oxygenation. So kind of like Leighton talked about with our goal. So kind of that like at or above 92 range, and all of the other subsequent like patient outcomes. We want them to have their chest tube discontinued. We really don't want to be sending a patient home on a chest tube at all. I don't think if ever we send patients on chest tubes, who knows? But I've never seen a patient sent home on chest tube. So that just increases site infection. And if there's not a need for it, we want that to get discontinued. We also want them to discontinue their PCA pump, if possible, and move to a more by mouth pain management. And especially like IV medications too, we want to get everything kind of switched over to a by mouth. So then the patients have less to worry about at home. They're not having to go into an infusion center to get pain meds, all of that good stuff. And we also want them to have a bowel movement. This is just because after surgery, things can just kind of slow down and kind of shut down. And we really want to make sure that all of their body systems are working before we let them free back into the world. We also want them to have a lack of any potential complications, and understand too the signs and symptoms of those complications. So, we don't want to see all of the stuff Leighton mentioned. We don't want to see arrhythmias. We don't want to see the pneumothorax. We don't want to see any signs of infection. And again, very heavily teach them of if these do happen, A, what do you do emergently? And B, like when you need to go be seen, like what are those symptoms? We would want to maybe initiate some home oxygen, especially if he's having trouble with managing COPD, exacerbations and not getting enough oxygen at home. We might want to kind of collaborate, maybe even with social work of, hey, how do we get this home oxygen? How do we set him up for success with that? We want the pain reduction to be to a minimal level. We don't want to be sending patients home with too much pain. We want to really figure out in the hospital, what does that good pain regimen look like? And just, again, making sure it's the by mouth medications. You can't be sending your patient home with an IV for pain medications because they can't give that to themselves. You might also really explore non-pharmacological pain interventions. I know for a lot of cancer patients, they're kind of in a chronic pain with their cancer. And so, heat, cold, aromatherapy is one that we touched on a lot in our clinical setting. And just, what can we do besides pain meds to help with your pain? We might also consider a referral to the Pulmonary Rehabilitation Center. And this is just kind of to help them regain their pulmonary strength, especially after having something removed. If you had to have a below the knee amputation, you would go to like the physical rehab place to kind of help regain that strength of how do you walk again? How do you regain your strength? So the pulmonary rehab, much like a physical rehab center, would help with getting the lungs kind of rehabilitated and accustomed to this new physiological change that has occurred. And then again, teaching. Teaching is a big, big deal. So we want to teach about oxygen safety at home. What are some of the risks? We don't want them to have candles. We don't want them to have oils, no open flames, stuff like that, just to ensure that they are staying safe. We also want to tell them about their post-surgical limitations. Oftentimes the provider will go over these, and a lot of it is us reinforcing what the provider said. And just making sure, oh, well, I see you doing this. Don't do that. Just gentle reminding them and teaching them again and providing them handouts and assessing how they learn and can remember those limitations because we don't want more problems to arise. We also want to talk with them about COPD safety considerations and just kind of what to look out for, medications, all of that sort of good stuff. We also want to talk with them about cancer risk factors. There are plenty of cancer risk factors that are modifiable, and we don't want them to keep continuing to make some of those choices. We want them to really change those if we can, especially if the lobe resection was successful and they're cancer-free now. We don't want that cancer coming back because they're constantly exposing themselves to another risk factor. We also want to teach them about new medications. Sometimes patients get sent home and it's like, here, start this new medication. And it's like, well, you can't just send them home without a thorough understanding. And as you're doing your medication checks, you can even be educating as you're doing it of, oh, hey, this is this medication. This is what it does. You explain it. And then maybe next time, if you have them on another shift, or the following nurse can be like, okay, the previous nurse told you about this medication. Can you teach me about the medication? And that can kind of help solidify that understanding of their new medications and kind of what they're used for and why. Again, going kind of with cancer risk factors is lifestyle modification. We want them to be living their healthiest, best life. And so really talking about what needs to be changed in order to live that healthy, best life. We might also explore with them, and maybe the social worker too, support group options and counseling, just because cancer is a very big diagnosis. So is COPD and having anxiety, and, he has kind of his support group with his church, but, really connecting him with people that kind of can understand what he's going through and can really provide support in those ways. And then we would really want to talk about medication adherence as well, with even new medications of, okay, you have to take this because this, and really explaining the importance of keeping up that regimen and what can happen if that regimen is not followed. So here come our NCLEX style questions. So first one is under the physiologic adaptation category. The veteran nurse is discussing complications of thoracic surgery with the new nurse freshly out of nursing school. The student nurse is the new nurse is curious about the newly inserted chest tube and what they have to watch out for in caring for it. The veteran nurse instructs the new grad to watch out for which symptoms. Select all that apply. Increasing shortness of breath, bradycardia, decreased respiratory rate, increased respiratory distress, crackles, and crepitus. Ooh. Hang on.
Your next question is, the student nurse is discussing actions they will need to implement with their patient after a robotic assisted thoracic surgery, which they did by lobectomy with the primary nurse. The student knows that which of the following is the priority intervention for the nurse to perform after this procedure. A, administer pain medication as prescribed. B, provide emotional support and education to the client and their family. C, monitor for signs of infection at each of the surgical sites. So at each of the sites the tubes went into. D, assist the patient to ambulate early and perform respiratory exercises.
The nurse is preparing to provide education to the patient and their family regarding discharge instructions. Which statements would require correction before talking to the patient and family? Select all that apply. You should avoid lifting more than 10 pounds for 3 weeks after discharge. Do not drive for at least 3 weeks after surgery. Shower within 12 hours of your chest tube removal. Continue incentive spirometry for at least a month after discharge. You can go on light walks for exercise as long as there are no stairs involved. You should expect it to take 4 to 6 weeks to return to baseline physical activity level. Here are our resources, and thank you for listening to our presentation.